You're listening to He Said, a cardiology board review series. No fluff, just facts.
This episode is about Tetralogy of Fallot. We'll talk about pre-repair issues, including the 4 abnormalities of Tetralogy of Fallot. Then we'll move on to repair itself, and then end with post-repair issues. So let's dive in. Recall the 4 abnormalities of Tetralogy of Fallot. First, a large subaortic VSD. Second, overriding aorta. Third, RV outflow tract obstruction. Fourth, resulting RV hypertrophy. Large subaortic VSD. Here, there is open communication between the left ventricle and the right ventricle. It is usually a perimembranous VSD, which is the one that occurs in 80% of all VSD. And second, most likely subarterial, which is the outlet VSD just below the aortic valve and beside the pulmonic valve VSD. Second, you'll have that overriding aorta, which means the aorta is positioned more rightward than usual and sits above the VSD. This is also known as anterior displacement of the conus septum. Third, you'll have that RV outflow tract obstruction. Flow to the lungs will be reduced. There is usually a combined valvular and subvalvular pulmonic stenosis. The pulmonic valvular annulus is small, the PV is thickened, and frequently bicuspid. Fourth is the resulting RV hypertrophy. RV hypertrophy results from having to pump harder against the RV outflow tract obstruction that comes from either valvular and or subvalvular pulmonic stenosis. Since the ventricular septal defect is large in most Tetralogy of Fallot patients, the pressures of the right ventricle and left ventricle are equal. The direction of the shunt through the VSD is right to left, since there is high resistance in the RV outflow tract due to pulmonic stenosis, which can be valvular or subvalvular, and also due to pulmonary atresia, which can be valvular or infundibular. The right to left shunting leads to systemic desaturation and cyanosis. The amount of pulmonary blood flow is the major determinant of symptoms in Tetralogy of Fallot. All Tetralogy of Fallot patients are expected to have elevated tricuspid regurgitation velocity, but almost none of them will have pulmonary artery hypertension. This is because the elevated pressure in the RV is a result of the large VSD, resulting in equalization of LV and RV pressures. In addition, the presence of pulmonary valve stenosis and or subvalvular pulmonary stenosis shields the pulmonary arterial bed from the pulmonary artery hypertension. The most common congenital defect that has large malalignment VSD and overriding great vessel is Tetralogy of Fallot. But the great vessel is not always the aorta. Other lookalikes are truncus arteriosus, double outlet right ventricle, detransposition of the great arteries with VSD, and pulmonary atresia with VSD. You need to know these lesions associated with Tetralogy of Fallot. 25% of Tetralogy of Fallot will have a right aortic arch, which you can see on chest x-ray. 15% of Tetralogy of Fallot will have a secundum ASD in addition to the VSD that's perimembranous. 2 to 10% of Tetralogy of Fallot will have anomalous coronary artery. Usually it is an LAD that comes from the right coronary sinus instead of the left coronary sinus. Now let's talk about the repair. There's the Blalock-Taussig shunt, the Waterston shunt and pot shunt, complete tetralogy repair, modified Blalock-Taussig shunt and central shunt, and contemporary surgery. Starting with the Blalock-Taussig shunt. The classic 1945 Blalock-Taussig shunt consists of an N2 side anastomosis of the subclavian artery to the pulmonary artery, allowing the aorta via the subclavian to send in blood flow to the pulmonary artery to get oxygenated despite the RV outflow tract obstruction. This method was beneficial in that it was able to grow together with the patient. However, although it resolved the paroxysms of Eisenmenger syndrome, patients continued to remain somewhat desaturated and suffered from complications of chronic hypoxemia and polycythemia. Also, these patients may have an absent pulse or low blood pressure in the ipsilateral arm. Next, we have the Waterston shunt and pot shunt. Because of the problems described above, attempts were made at creating a systemic to pulmonary artery shunt, and this resulted in the Waterston shunt, which involved creating an aortopulmonary window from the ascending aorta to the right pulmonary artery, and the pot shunt, which involved creating an aortopulmonary window from the descending aorta to the left pulmonary artery. The Waterston and pot shunts provided blood flow to the pulmonary circulation that was torrential and unfortunately one-sided. Soon, the era of complete repair of Tetralogy of Fallot was ushered in 1954. The VSD was closed by a surgical patch, the RV outflow tract was reconstructed and enlarged using extracorporeal circulation. As many of these patients who underwent complete repair of Tetralogy of Fallot were previously patients who underwent Waterston or pot shunts, which caused torrential one-sided flow to the pulmonary circulation, it was found that they had a high incidence of pulmonary artery distortion and pulmonary vascular disease, often in a single lung. This problem led to the advent of the use of Gore-Tex tubes. The prior concern about the short longevity of Gore-Tex tubes was no longer an issue since complete repair could be undertaken at low risk on most patients during infancy. The modified Blalock-Taussig shunt consisted of a Gore-Tex tube from the right innominate artery or the right subclavian artery to the right pulmonary artery. The central shunt consisted of a Gore-Tex tube from the ascending aorta to the main pulmonary artery. A stable and predictable flow can be obtained by choosing the size of the Gore-Tex shunt and the site of the anastomosis. Over the past 3 decades, if the cardiac anatomy is favorable, total correction can be performed anytime, even during the neonatal period, and is favored over temporizing surgery. Total correction involves patch closure of the VSD, infundibulectomy, pulmonary valvotomy, repair of pulmonary artery branches if necessary, and repair of associated defects such as concomitant ASD or PDA. A transannular patch is avoided to prevent development of pulmonary regurgitation, RV outflow tract aneurysm, and RV dysfunction. Attempts will be made to preserve the pulmonary valve to prevent the development of pulmonary regurgitation. Attempts will be made as best as possible to repair the VSD through an atriotomy because creating a ventriculotomy will lead to RV dysfunction in the future. However, there are several situations where a temporizing procedure, such as MBTS or essential shunt, is done instead of a one-stage total correction. 1 is small pulmonary arteries. 2 is coronary anomaly of LAD arising from the RCA or from the right sinus of Valsalva and crossing the RVOT, which occurs in 10% of tetralogy patients, which can be damaged at the time of surgery. 3 is low birth weight premature neonate. And 4 is presence of complicated associated congenital anomalies such as atrioventricular septal defect or mitral valve anomaly. Those are the situations where a temporizing procedure can still be done instead of a one-stage total correction of Tetralogy of Fallot. Now let's move on to post-repair issues. How do you examine a patient with repaired Tetralogy of Fallot? You really have to pay attention to several physical exam findings that will reflect residual hemodynamic abnormalities. There may be an RV heave from residual RV hypertrophy. There may be a PR murmur, pulmonary regurgitation murmur, that is brief and quiet due to near equalization of diastolic pressures in the right ventricle and pulmonary artery. There may be a systolic ejection murmur due to residual right ventricular outflow tract obstruction, such as branch PA stenosis. And oxygen saturation is usually normal. You want to watch out for signs of a failing right heart, such as JVD, LEE, and hepatomegaly, which need investigation. In repaired Tetralogy of Fallot, there is almost always pulmonary regurgitation. You can see this on parasternal short axis color Doppler and Doppler CW. This occurs because Tetralogy of Fallot repair requires placing a transannular patch across the RV outflow tract and pulmonary annulus to relieve the infundibular and valvular pulmonic stenosis that is a critical part of this lesion. Because of this patch, the pulmonary valve becomes incompetent, often with significant valvular regurgitation, causing a right ventricular volume overload that eventually leads to arrhythmia and right ventricular dysfunction. In a repaired Tetralogy of Fallot patient, although pulmonic valve regurgitation is tolerated for many years, over time, RV volume overload may cause RV dysfunction and diminish exercise tolerance. So, symptomatic pulmonic regurgitation that is moderate or greater in severity should get pulmonic valve replacement. You don't wait until it becomes severe pulmonic regurgitation. Clues to post-tetralogy repair pulmonic regurgitation are cardiomegaly on chest X-ray, right ventricular enlargement, arrhythmias, dyspnea and fatigue, and tricuspid regurgitation. CW Doppler of the pulmonic valve after the expected systolic forward flow that is a downward hub will show an upward or regurgitant diastolic sawtooth shape that has a rapid deceleration of the diastolic regurgitant flow signal, indicating an equilibration of pulmonary artery and RV diastolic pressures, which is what occurs when there is severe pulmonary insufficiency. Because repaired tetralogy of Fallot almost always has pulmonary regurgitation, the 2018 congenital heart guidelines say, and moderate or greater pulmonic regurgitation with other lesions requiring surgical interventions. That is a Class 2B recommendation. Pulmonary valve replacement, in addition to arrhythmia management, may be considered for adults with repaired tetralogy of Fallot and moderate or greater pulmonic regurgitation and ventricular tachyarrhythmia, Class 2B. Symptomatic patients, symptoms meaning dyspnea, chest pain, and/or exercise intolerance otherwise explained, with tetralogy of Fallot that is repaired and severe pulmonic regurgitation who undergo pulmonary valve replacement often report functional class improvement after intervention. Improvement in symptoms often correlates with a reduction in right ventricular size and relief of pulmonic regurgitation. Symptom improvement is more likely in patients with underlying PS and PR than in patients with PR alone. How about asymptomatic patients with moderate or severe PR? Pulmonary valve replacement, surgical or percutaneous, is reasonable for preservation of ventricular size and function in asymptomatic patients with repaired tetralogy of Fallot and ventricular enlargement or dysfunction, and moderate or greater pulmonic regurgitation. That's a Class 2A recommendation. Specifically, they say that for asymptomatic patients, pulmonary valve replacement is reasonable if there is any of RV systolic pressure elevated due to RVOT obstruction of at least 2/3 systemic pressure, mild or moderate RV or LV systolic dysfunction, severe RV dilation, which is any of an index RV end diastolic volume more than 160 milliliters per meter square, or an index RV end systolic volume of 80 milliliters per meter square or more, or an RV EDV that is at least 2 times the LV EDV. Those are the criteria for severe RV dilation, or progressive reduction in exercise tolerance. So if you have 2 of any of these 4, then you can do pulmonary valve replacement in asymptomatic patients. Now, how about post-repair arrhythmias? In tetralogy of Fallot, the prevalence of atrial and ventricular arrhythmias steeply increases after 45 years of age. 20% of tetralogy of Fallot patients have atrial arrhythmias and 15% have ventricular arrhythmias. The incidence of sudden cardiac death after surgical repair of tetralogy of Fallot is approximately 2% per decade. Surgical repair of tetralogy of Fallot has evolved over time, with relief of the RV outflow tract obstruction usually involving infundibulotomy, resection of the obstructive muscle bundles, and use of a patch to enlarge the pathway from the right ventricle to the pulmonary arteries. These procedures result in scar tissue and create a dyskinetic and often aneurysmal area in the RV outflow tract. Adults with repaired tetralogy of Fallot face an increased risk of arrhythmias, exercise intolerance, heart failure, and death beginning in early adulthood. Repaired tetralogy of Fallot patients now have excellent survival into adulthood. There's a 0.15% annual risk of sudden cardiac death. A resting QRS duration of at least 180 milliseconds has been associated with sudden cardiac death in this population. In repaired tetralogy of Fallot, if you have new VT, you are going to find severe pulmonary regurgitation on echo. If the repaired tetralogy of Fallot patient has arrhythmogenic syncope, non-sustained VT on Holter, and EKG showing an right bundle branch block with QRS duration of more than 180 milliseconds, then you need to give them an ICD to reduce the risk of sudden cardiac death. The 2018 congenital heart guidelines say primary prevention ICD therapy is reasonable in adults with tetralogy of Fallot and multiple risk factors for sudden cardiac death, Class 2A recommendation. The additional risk factors for sudden cardiac death and tetralogy of Fallot are LV systolic or diastolic dysfunction, non-sustained ventricular tachycardia, QRS duration of 180 milliseconds or above, extensive RV scarring, and inducible sustained VT at electrophysiological study. Amiodarone is not indicated to reduce the risk of sudden cardiac death, but could be considered if the patient had a high burden of ventricular arrhythmias after ICD placement. Other post-repair problems in tetralogy of Fallot are residual pulmonary stenosis, residual ventricular septal defect, and aortic regurgitation. That's all I have for you for Tetralogy of Fallot. We went over the pre-repair issues, the repair options, and post-repair issues.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.